Welcome all to the class. So today's topic is the management of nausea and vomiting in pregnancy and hyperemesis gravidarum. This is Green Top Guideline number 69. This is recently updated in 2024. Previous guideline was also there, I think 2016 guideline, but this is updated guideline. So it's better to go through updated guidelines. Okay, so we'll start with today's presentation. So first, any Green Top guideline, when we see, we will always have these key recommendations in the beginning. And these key recommendations are nothing but the summaries of the whole guideline. So we should know this is must. So they are written in a bold type at the beginning of any Green Top guideline, and then individual sentence or individual recommendation is then elaborated in the subsequently in next pages. Okay, so every guideline you might find 20 to 80 pages also. There may be some 100 pages also in some guideline, but this key recommendation is nothing but the summary of the guideline. Okay, so this summary you have to know, and what is the justification, what are the trials on which these recommendations are made, that will be there detail in the guideline. And at the end there will be appendix, there will be certain flow charts. You have to go through each and everything. So most of the candidate, what do? They read the guideline, but they don't go through the appendix. Okay, and there are certain flow charts and there are certain SBAs or EMQs which are asked on those also. Okay, so we begin with the key recommendations of this Green Top Guideline number 69, which is there on the nausea and vomiting in pregnancy and hyperemesis gravidarum. So classification of severity of nausea, vomiting in pregnancy and hyperemesis gravidarum. So these two are different things: nausea, vomiting of pregnancy, and hyperemesis gravidarum. Okay, hyperemesis gravidarum is a severe form. Okay, nausea, vomiting of pregnancy is more mild form, more common. Okay, now how these things are classified? So there is objective and validated index for classification, and there are two indices which you should know. One is a pregnancy unique quantification of emesis, and second, hyperemesis level prediction, that is HELP. So these two scoring systems which you should know. One is a PUQE, that is pregnancy unique quantification of emesis. Second is HELP, that is hyperemesis level prediction. Okay, so these two things you should note it down. So ketonuria is not an indicator for dehydration and should not be used to assess the severity. So in traditionally what we used to say, when there is a ketonuria, that means it is a severe form of nausea and vomiting or hyperemesis, what we call it. But this current guideline says ketonuria is not an indicator of dehydration and should not be used to assess the severity. Okay, so coming to the management, what does the recommendations are there? You have first line antiemetics such as antihistaminics, phenothiazines, and doxylamine plus pyridoxine combination. So first line antiemetics will include antihistamines, phenothiazines, and doxylamine and pyridoxine combination. Now, in second line, we have 2 or 3 drugs in which mainly there is ondansetron, metoclopramide, and there is another, that is domperidone. Okay, but specific things, there are about two drugs in second line. About ondansetron. Ondansetron is a safe and effective. It is a second line antiemetic. If the first line antiemetics are ineffective, then this second line will be used, and small increase in the absolute risk of orofacial clefting with ondansetron use in first trimester, which should be balanced with the risk of poorly managed hyperemesis gravidarum. Okay, so this particular drug, ondansetron, is associated with small increased risk of orofacial clefting, and this risk is very, very negligible, but there is a small risk that we should counsel to the patient. Okay, and that is why it is considered as a second line antiemetic, but still it is safe. Okay, and that is why we have to keep balance with the poorly managed hyperemesis gravidarum and starting of this particular ondansetron for its adverse reaction. Then drug is a metoclopramide. So metoclopramide is also safe and effective and can be used alone or in combination with other antiemetics as a second line drug, but it has got a risk of extrapyramidal effect. So slow bolus injection or at least 3 minutes. So this particular line which is highlighted in red or which is red in color, you should remember metoclopramide is safe in pregnancy. It is a second line drug, but it has got a risk of extrapyramidal effect and it has to be given in a slow bolus injection over a period of 3 minutes to decrease the risk of extrapyramidal effects. Then normal saline, that is 0.9% NaCl with addition of KCl, that is potassium chloride, in each bag with administration guided by daily monitoring of electrolyte is the most important IV hydration. So once the patient is admitted, either inpatient or if it is an ambulatory care, in that particular case, patient requires IV fluid therapy, and the fluid of choice is normal saline, 0.9% normal saline with addition of KCl, potassium chloride. Remember this because the question, SBA question is asked on this. Okay. Then what is the prevalence of nausea and vomiting in pregnancy? So 90% of pregnant women, it is seen, and it is the commonest indication for hospital admission. Generally, the hospital stay is for 3 to 4 days for the nausea and vomiting in pregnancy. Nausea vomiting of pregnancy is defined as symptom of nausea and vomiting during pregnancy when onset is prior to 16 weeks of gestation and where there are no other causes. So just remember these particular things. There is a nausea, vomiting during the pregnancy, but the onset is before 16 weeks of gestation. This 16 weeks, you should know what is the cutoff which they have put to label this as a nausea, vomiting of pregnancy, and there should be no other underlying cause. Okay, so hyperemesis gravidarum. Now we are discussing about hyperemesis gravidarum. Hyperemesis gravidarum is a severe form of nausea and vomiting in pregnancy, which affects between 0.3 to 3.6% of pregnant women and interferes with the quality of life and the ability to eat and drink normally. Okay, so this hyperemesis gravidarum, how does it differ from the nausea and vomiting in pregnancy? First, the prevalence is low. 90% prevalence will be there for nausea and vomiting in pregnancy. But for hyperemesis, the prevalence is 0.3 to 3.6% of pregnant women will suffer from hyperemesis gravidarum, which is a severe form of nausea, vomiting in pregnancy, and it interferes with the quality of life and ability to eat and drink normally. Now, what is the mechanism of nausea, vomiting in pregnancy and hyperemesis gravidarum? So, hypersensitivity to vomiting hormone growth differentiation factor, that is GDF15. Okay, there is a hypersensitivity to vomiting hormone growth differentiation factor, GDF15, and this GDF15 causes loss of appetite, taste aversion, nausea, vomiting, and weight loss. So in the mechanism of hyperemesis gravidarum or the nausea, vomiting, pregnancy in gravidarum, which factor is considered responsible? It is a GDF15. There is a hypersensitivity to this particular factor, and that leads to loss of appetite, taste aversion, nausea, vomiting, and weight loss. Hyperemesis gravidarum can be diagnosed when symptoms start in early pregnancy. Nausea and vomiting are severe. Okay, so hyperemesis gravidarum, again, symptom will be early in pregnancy, but severe form. And in pathophysiology, you should remember the GDF15 because that can be asked as a SB. Okay. And also these figures which I have discussed, the prevalence of nausea, vomiting in pregnancy, 90% prevalence of nausea, vomiting in pregnancy, and hyperemesis prevalence is around 0.3 to 3.6%. If you see the older guideline, they have mentioned about 80% prevalence. So last 2 years back, the prevalence which they have mentioned was 80%, but now they say it is a 90%. So sometimes, you know, in answer, if you don't find 90% and if you have 80% as an option, you can select that also. Depends upon the option which they are giving. Okay, but current guideline mentions the prevalence as a 90%. While the severe hyperemesis gravidarum, it is a very less in prevalence, 0.8 to 3.6%. Okay. Now, hyperemesis gravidarum is a severe form of nausea and vomiting, and it is causes the inability to eat and drink normally and strongly limits daily activities of living. So when we discuss about hyperemesis gravidarum, always mention that there is a nausea, vomiting which are severe in nature, and not only that, there is inability to eat and drink normally, and there is a affection of the daily activities. Okay, so quality of life gets affected. This is one of the important things. Okay, signs of dehydration are contributed to diagnosis. Okay, this definition represents a shift from historic reliance on the objective measures such as weight loss, electrolyte imbalance, etc., etc. Okay, so the signs of dehydration are contributory, but primarily they are focusing on severe nausea and vomiting and inability to eat and drink and quality of life affections. So these are the focus things in the definition. Okay, but the signs of dehydration are contributory for the diagnosis. Previously, it is mainly the weight loss and electrolyte imbalance. These were the objective measures. They were used for the defining the hyperemesis gravidarum. Nowadays, weight loss and electrolyte imbalance, they are second. Okay. So coming to the scoring. Now, pregnancy unique quantification of MSC score. Now, what is this particular score? It can be used to determine whether nausea vomiting of pregnancy is mild, moderate, or severe. So what you can do, you can quantify the nausea vomiting of pregnancy into mild, moderate, or severe. Okay. Not only that, you can use this score for monitoring the response to the treatment. But most important thing that PUQE score can be used for monitoring the treatment for mild and moderate cases, but it is not used for monitoring severe form of nausea vomiting in pregnancy and hyperemesis gravidarum. So importance is that this PUQE score can be used for quantification, mild, moderate, or severe. And you can also assess the response to the treatment in mild and moderate cases, but not valid for severe nausea vomiting in pregnancy and hyperemesis. Okay. Now, second score is a HELP score. Okay. Now, this score is used to quantify the hyperemesis gravidarum symptoms into a score that can be trended over a time and to monitor the progress and response to the treatment. Okay. So this can be used to monitor the response to the treatment also. Okay. Then nausea, vomiting in pregnancy, and hyperemesis gravidarum are associated with hyponatremia, hypokalemia, low serum urea, raised hematocrit, and ketonuria with metabolic hypochloremic alkalosis. This sentence is very, very important because SBA is frequently asked on this, that what is the metabolic change in hyperemesis gravidarum. Okay, and you get multiple options. Like one option will be there: decrease sodium, decrease potassium, and decrease serum urea. Another will be increase sodium, decrease potassium, increase serum urea, and multiple combinations and permutations will be there. Okay, so when there are multiple things, you do get confused. But remember, it is a metabolic alkalosis and there is a metabolic hypochloremic alkalosis. Okay, and there is a reduction in the sodium level, reduction in the potassium level, and serum urea is also low. Okay, unless there is a severe dehydration leading to AKI, that is acute kidney injury. Okay, so in the mild moderate cases, there will be hyponatremia, hypokalemia, low serum urea, raised hematocrit, and ketonuria with metabolic hypochloremic alkalosis. Okay, if severe, there may be metabolic acidosis, and in 2/3 of cases, that is 67% of women with hyperemesis gravidarum, there may be abnormal thyroid function test. Okay, again, this is one of the SBA. In how many percent of patients there will be abnormal thyroid function which is seen? So almost 2/3 of cases of hyperemesis gravidarum will have this abnormal thyroid function, that is 67% cases. Okay, a raised T4 and low TSH therefore do not need treatment in a straightforward nausea vomiting in pregnancy or hyperemesis gravidarum where the cause is clear and the patient is responding to the treatment. Okay, so if you get the parameter such as there is an increase in T4 level and TSH level is reduced, in that particular case treatment is not required if the cause is nausea vomiting in pregnancy. Okay, again, this can be asked as a SBA, that you will be given the values of T3, T4, TSH, and you will be asked about the further management. These patients do not require treatment if the cause is nausea vomiting in pregnancy and the patient is responding to the treatment. You don't have to correct these thyroid abnormalities. And in how many percent of patients you will see thyroid abnormalities? In 2/3 of patients. Sometimes they will not give, but they will give you percentages. So 67%. It may be 65 or something like that. So nearby option you need to select. Okay. Then coming to the liver function test. Liver function tests are abnormal in 40% of women with hyperemesis gravidarum, with most likely abnormality being a rise in transaminases. So LFTs are abnormal in 40% of patients, while thyroid function tests are abnormal in 67% of patients. Okay, so 2/3 patients will have thyroid function abnormalities, and 40% patient will have liver function abnormalities. Okay, so you just remember L comes early in this series of alphabets, then comes T. So the 40 figure is corresponding with the LFT, and 67% is, so these two figures, if you remember, don't confuse which one is which. Okay, so thyroid function 67% abnormality, and LFT is in 40% of cases. Okay, now coming to the next, that is, how should women with nausea, vomiting in pregnancy and hyperemesis gravidarum be careful? So this is the further is a treatment aspect. Up till now, we have seen the definition, we have seen about the electrolyte imbalance and what exactly metabolic change is seen in hyperemesis gravidarum, etc. Now coming to the management part. So what does the guideline says? Guideline says women with mild nausea, vomiting in pregnancy, management is in the community with antiemetics. Okay, so it is a community based management with antiemetics, use of oral medicines. Okay, when community or primary care measures have failed, then go for ambulatory daycare management. Okay, and third is inpatient care should be considered if there is at least one of the following. So there are three types of management. One is a community care with antiemetics, second is ambulatory care, and third is inpatient care. So for which patients the inpatient care is required? Inpatient care will be required if there is a continuous nausea, vomiting in pregnancy and inability to keep down oral with antiemetics. So if the oral antiemetics are not effective, the continuous nausea, vomiting in pregnancy is there, you go for inpatient care. Then continued nausea, vomiting in pregnancy is associated with clinical dehydration and weight loss more than 5%. Okay, despite oral antibiotics. Okay. Then third is a confirmed or suspected comorbidity. If there is a UTI infection and you need to start oral antibiotic, but because of vomiting, the patient is not going to tolerate antibiotics also, you need to admit and give parenteral treatment. Okay. Then another comorbidity, that the patient is having some medical condition like epilepsy, diabetes, for which she is requiring some kind of medicine, or she is on some medicine and which is not getting tolerated because of nausea and vomiting, and likely that she will land up with complications. So comorbidities such as epilepsy, diabetes, HIV, hypoadrenalism, or psychiatric disease, where the symptoms and inability to tolerate oral intake and medication could present further complication. Okay. So these are the indications for inpatient management. So sometimes they will give you the scenario and will ask you what is going to be the next step. Okay, so the options will be oral antibiotic and community care, the oral antiemetic and community care, or ambulatory day care, etc. So depending upon scenario and the findings which are given, you need to select the appropriate type of management for that patient. Okay, that is why this particular slide is very, very important. Now, where inpatient care is required, the ultrasound scan should be scheduled to confirm viability and gestational age and to assess for multiple pregnancy and tropoplastic disease. So these are two important things which you need to rule out. Once the patient is requiring inpatient admission, then you need to go for ultrasound and you need to rule out one is a multiple pregnancy and tropoplastic disease. Okay, and it is a routine scan, not an urgent scan, but you need to rule it out. Okay, now let's see about the what are the management with the drugs and all. So when there is no response to single antiemetic, what we should do, you can use combination of drugs. Okay, if single drug is not effective, then go for combination of drugs. Then only licensed treatment of nausea, vomiting in pregnancy in the UK is delayed release of combination of doxylamine and pyridoxine. Remember, this is the only approved treatment, that is doxylamine and pyridoxine, that is vitamin B6, licensed treatment for nausea, vomiting in pregnancy. And it is a first line treatment for mild to moderate nausea, vomiting in pregnancy. Okay, so if you are asked about the first line, oral antibiotic, oral antiemetic, in which doxylamine and pyridoxine combination, and it is a delayed release. So if you have a multiple options, and in which if you have a delayed release combination of doxylamine and pyridoxine, you select that option. Okay, delayed release combination of doxylamine and pyridoxine is the first line treatment. Okay, then for women with persistent or severe hyperemesis gravidarum, the parenteral, then transdermal or rectal route may be necessary and more effective than oral regimen. Okay, so if the patient is not getting control, then severe hyperemesis, you may go for parenteral or transdermal or rectal route. Okay, then third line, you have corticosteroids. It should be reserved for cases where standard therapies have been ineffective and used in combination with antiemetics. So this is a third line. Okay, corticosteroids are the third line drug. And what is the dose and schedule? So when we start with the corticosteroids, we give IV hydrocortisone 100 milligram twice a day. Okay, 100 milligram twice a day intravenously. And once there is a clinical improvement, in that particular case, we will make it oral prednisolone 40 to 50 milligram per day and then taper it down slowly to a maintenance dose. Okay, so start with hydrocortisone IV 100 milligram BD, then convert it to oral prednisolone 40 to 50 milligram daily, then slowly taper to the lowest prednisolone dose. Okay, and once the things subside well, along with antiemetics, then you can curtail or stop these oral corticosteroids also. Okay, so prednisolone needs to be continued until the gestational age at which hyperemesis gravidarum would have resolved, and in extreme cases, prednisolone is continued until birth. Okay, women receiving corticosteroids should be screened for gestational diabetes mellitus. We know the steroids are known to cause the imbalance with the glucose metabolism, and hence we need to screen them for gestational diabetes mellitus. I hope this is clear to all of you. Okay, so we'll go with the next slide. Okay. What is the safety of pharmacological agents used to treat nausea, vomiting in pregnancy in hyperemesis gravidarum? So we have seen there is a first line drug, second line drug, third line is a corticosteroid. Now let us talk about the safety of each drug. Okay, first line, there are safety data for antiemetics such as antihistaminics, phenothiazines, and pyridoxine doxylamine combination, and they should be prescribed initially when required for nausea, vomiting in pregnancy and hyperemesis gravidarum. So first line drugs are absolutely safe and include antihistaminics, phenothiazines, and pyridoxine doxylamine combination. Now coming to the second line. Second line, mainly two drugs we have seen. One is a metoclopramide and second is ondansetron. With ondansetron, we have seen there is a orofacial clefting. Now what does the guideline say? There is evidence that ondansetron is safe. It should not be discouraged if the first line antiemetics are ineffective. That means it can be used, and women can be reassured regarding a very small increase in the absolute risk of orofacial clefting with ondansetron use in the first trimester, which should be balanced with the risk of poorly managed hyperemesis gravidarum. Okay, absolute risk of orofacial clefting increases from a background risk of 11 cases per 10,000 births to 14 cases per 10,000 births with ondansetron. So there is a very small increase. So even if she doesn't take the ondansetron, then also there is a background risk of 11 cases per 1,000. That is increasing to 14 cases per 10,000. Okay, so there is a very small increase in the risk of orofacial clefting with the first trimester use of ondansetron. That needs to be counseled to the patient. Then second drug is a metoclopramide. Metoclopramide is a safe and can be used either alone or in combination with the antiemetics. Okay, so this drug has got a side effect of extrapyramidal effects. Metoclopramide should be used as a second line therapy. IV doses should be administered by slow bolus injection over at least 3 minutes to help to minimize these complications like extrapyramidal effects. And women should not be prescribed medication that have caused previous adverse reactions. So if you have got, if she has got any history of adverse reaction previously, then that drug we are not going to use. So this is about the safety. Now let's see about the adverse effect which can happen in patients with nausea, vomiting in pregnancy and hyperemesis and how they can be prevented. So nausea and vomiting of pregnancy can lead to electrolyte imbalance. Okay, so what we need to do once the patient is admitted, we need to monitor urea and serum electrolytes levels should be checked daily in women who require IV fluid. Okay, those women who are admitted require IV fluids, we will monitor urea and serum electrolytes daily. Okay. Second complication, recurrent intractable vomiting can lead to GERD or GORD, that is gastroesophageal reflux disease, esophagitis, and gastritis. So this can be one of the complications because of hyperemesis. Okay, intractable vomiting can lead to this, and what we can use is a H2 receptor blocker or a PPI, that is proton pump inhibitor, may be used for women developing gastroesophageal reflux disease. So there can be SBA or EMQ that the patient was on such and such medication primary but not getting control, has recurrent intractable vomiting, and what drug needs to be added. So here H2 receptor blockers or proton pump inhibitors, because the complication can be GORD or esophagitis or gastritis. Okay, then nausea, vomiting in pregnancy or hyperemesis gravidarum can lead to Wernicke's encephalopathy due to vitamin B1, that is thiamine deficiency. Okay, so again this is one of the SBA, that Wernicke's encephalopathy is due to deficiency of which vitamin? It is a vitamin B1 or thiamine deficiency in hyperemesis gravidarum can lead to this. Okay, so what we have to do? Thiamine supplementation, either oral 100 milligram TDS or IV to all women admitted with vomiting or severely reduced dietary intake, especially before administration of dextrose or parenteral nutrition. This has been observed when you give dextrose, 5% dextrose or parenteral nutrition. These patients, if you do not supply thiamine, they will land up with the Wernicke's encephalopathy. That is why the fluid of choice is a 0.9% normal saline. With 5% dextrose, there are chances that Wernicke's encephalopathy can happen. Okay, and that is why if at all dextrose is to be used, then it has to be used along with the thiamine supplementation. But the fluid of choice is a 0.9% normal saline, and this you remember because they will give you 0.45% normal saline. They may give you some 0.7% and various options. So it's very clear, 0.9% normal saline with KCl with daily monitoring of the urea and electrolytes. That is the management in cases of hyperemesis gravidarum. Now, GERD treatment, what we need to do? Add proton pump inhibitor along with antiemetics, and proton pump inhibitor treatment improves pregnancy unique quantification 24 scores and improved quality of life scores. Okay, so these proton pump inhibitors are useful in patients if they have GERD. Okay, and it improves the quality of life also. Okay, now what further complication can happen because of hyperemesis gravidarum? Once the patient is admitted, she is at risk of development of the venous thromboembolism. Okay, the odds ratio for development of the risk of VTE is around 2.5. Okay, because of the hyperemesis gravidarum. So then what is the recommendation? Admitted with hyperemesis gravidarum should be offered low molecular weight heparin till admitted. Okay, so this particular question can be asked, what is the duration and what is the treatment? So low molecular weight prophylactic heparin we need to add. They may give you the weight also, then accordingly we have to calculate the dose of LMW, and the duration will be till admitted. Okay, once the patient is discharged, then you have to stop it. Okay, then when the patient is in the community, you need to assess the risk for venous thromboembolism and suggest the graduated compression stockings. Okay, so venous thromboembolism is another complication which can happen, and admitted patients you will give low molecular weight heparin till her hospitalization. Now, oral iron can lead to nausea, vomiting, and constipation. So, if at all the patient is having nausea, vomiting, oral iron better not to start at that particular time. So, previous or current nausea, vomiting of pregnancy or hyperemesis gravidarum should consider avoiding iron-containing preparation if these exacerbate symptoms, or consider alternative route of administering iron. Okay, so nausea, vomiting on pregnancy will aggravate this particular condition. So avoid iron containing preparation or consider alternative route of administration. Then commonly suffer with constipation because of reduced food intake and fluid intake, and if treated with ondansetron. Constipation is common in these patients, those who have hyperemesis gravidarum, and that is mainly because of the food intake is reduced, fluid intake is reduced, and it is also seen in patients with ondansetron. So with ondansetron, two things we have seen. One is orofacial clefting, and second is about associated constipation. Okay, so what is the recommendation? Offer laxatives if the patient is constipated, and particularly if ondansetron is used. So if the patient is on ondansetron, you may require laxity. Okay. Now, what adverse effects can occur from nausea, vomiting in pregnancy and hyperemesis gravidarum? How they can be prevented? Okay. Now, patient may require OGD-scopy, that is esophago-gastroduodenoscopy, which is safe in pregnancy and indicated in cases of hematemesis or severe epigastric pain. A therapeutic trial with proton pump inhibitor is appropriate for treatment and prevention, and it is safe in pregnancy. Okay, so OGD-scopy sometimes will be required if there is a hematemesis or severe epigastric pain. So there can be a question on the next step or next best investigation, and if there is a hyperemesis case with hematemesis or severe epigastric pain, the investigation of choice will be esophago-gastroduodenoscopy. Okay. The next is a Wernicke's encephalopathy due to vitamin B1, that is thiamine deficiency. Classically, it will present with blurred vision, unsteadiness, and confusion. There will be memory problems, drowsiness, and on examination, there will be nystagmus, ophthalmoplegia, hyporeflexia, areflexia, gait and finger nose ataxia. In hyperemesis gravidarum, the presentation tends to be episodic and slow in onset. Wernicke's encephalopathy is potentially fatal medical emergency. In the context of hyperemesis gravidarum, it is preventable. Studies have stressed the association between Wernicke's encephalopathy and administration of IV dextrose and parenteral nutrition. This we have already discussed. The fluid of choice is 0.9% normal saline. Dextrose is to be avoided. Okay, parenteral nutrition and IV dextrose, they have got association with Wernicke's encephalopathy. Okay. Almost 1/3 of women will be readmitted within the same pregnancy. Sometimes they can ask you the question, the patient has got a query that, doctor, what will be the risk for the repeated admission? So almost 33% patient will require repeat admission in the same pregnancy because of hyperemesis. So you control discharge, but there is a 1/3 chance that she can come back again for the admission. Now coming to the optimal rehydration and regimens for ambulatory and inpatient. Okay, so we have seen community management, we have seen ambulatory care is also there, and third is the inpatient management. So once it comes to the oral rehydration, IV rehydration, what is the recommendation? So normal saline, 0.9% normal saline with addition of KCl in each bag, with administration guided by daily monitoring of electrolytes. Okay, that is the recommended treatment. Use of dextrose infusion for fluid replacement in nausea, vomiting in pregnancy is not recommended. Okay, may precipitate Wernicke's encephalopathy in thiamine deficient states. Now, next is a enteral and parenteral nutrition. When to start and what is the risk to the woman and the fetus? So, parenteral nutrition should only be considered as a multidisciplinary approach when all the treatments have failed to sufficiently control symptoms, as it is inconvenient, expensive, and can be associated with serious complications such as thrombosis, metabolic disturbances, and infection. So parenteral nutrition, we have option, okay, but it should be considered as after the multidisciplinary discussion, and there should be failure of all steps. Okay, then in that what we have enteral tube feeding options to consider, and it will include nasogastric, nasoduodenal, and nasojejunal tube. Okay, or what we can use a percutaneous endoscopic gastrostomy or gastrojejunostomy feeding, all of which should only be considered in consultation with gastroenterology and with multidisciplinary approach. So when we are talking about enteral tube feeding, in that particular case, the multidisciplinary approach, involvement of the gastroenterologist is important. And the option we have, we can use nasogastric tube, we can use nasoduodenal tube, then nasojejunal tubes can be used, or percutaneous endoscopic gastrostomy or gastrojejunostomy can be used, but along with the gastroenterologist. Then parenteral feeding with PICC line, that is peripherally inserted central catheter. Okay, so parenteral feeding with peripherally inserted central catheter is often better tolerated than enteral feeding. However, it carries a higher risk of infection and vascular complication. So what we have seen initially, oral antiemetics, then comes ambulatory management, then comes hospital admission on IV fluids and IV treatment. Okay, then second line, third line is there, and after that comes the enteral and parenteral, but there should be multidisciplinary approach, okay, with the involvement of the gastroenterologist, okay, and in that also parenteral feeding with PICC line is better than the enteral feeding, okay, but it has got a risk of infection and vascular complication. Now coming to the when to terminate the pregnancy. Hyperemesis gravidarum has got a high risk of termination of pregnancy. 10% of women with hyperemesis gravidarum undergo termination of pregnancy due to severity of symptoms who otherwise would not have undergone termination of pregnancy. Okay, so what is the risk? How many patients will offer termination of pregnancy? Almost 10% of the termination of pregnancy can happen because of this hyperemesis gravidarum. Okay, but when to terminate the pregnancy, that is most important. Treatment options like antiemetics, corticosteroids, enteral or parenteral feeding, and correction of electrolyte and metabolic disturbances should be considered before deciding the option of termination of pregnancy. So we have to try with antiemetics, corticosteroids, enteral, parenteral feeding, and correction of electrolyte and metabolic disturbance. Consider seeking psychiatric opinion if there are concerns regarding mental health, and the decision for termination of pregnancy needs to be multidisciplinary with the documentation of therapeutic failure if this is the reason for the termination. So first thing, you have to try all options which are available. Then also, if required, we need to get a psychiatric consultation, and multidisciplinary management is there, and we have to document that there is a therapeutic failure in management of the hyperemesis gravidarum, and then you go for termination. Okay, women should be offered counseling before and after decision for pregnancy termination. Okay? Long-term effects of nausea, vomiting, and pregnancy. Women who experience hyperemesis gravidarum in pregnancy are at increased risk of postnatal depression, anxiety, post-traumatic stress disorder in the postpartum period. So what are the things which are common in long term? Postnatal depression, anxiety, post-traumatic stress disorder. Okay, there is a risk of recurrence in future pregnancy, 15 to 81%. Okay, this is also SBA. What is the risk? The patient is asking that what is the risk for me to develop again hyperemesis in next pregnancy? It is around 15 to 81%. Okay, a low recurrence risk with preemptive antiemetics before symptoms begin. So in the next pregnancy, such patients you can start with antiemetics early. Okay, before the patient develops symptoms, if you start, then the severity will be less. Okay. Now this is about this chart is about pregnancy unit quantification index. This is called as PUQE 24 score. One of the important things which you should remember that though it is called as PUQE 24 score, it does not mean the total score is 24. This 24 is for last 24 hours. So this score is calculated in the last 24 hours. Okay, but the total score is 15. So this is divided into mild, moderate, and severe. Okay, so mild is 6 up to 6 score, then moderate score is from 7 to 12, and severe score is 13 to 15. Okay, so these particular scoring, remember, maximum score is 15. There are certain minor things, but you should know, because though the score is PUQE 24, it doesn't mean the total score is 24. Okay, now what are the things which are taken into account? It is in last 24 hours, how long have you been nauseated or sick to your stomach? In last 24 hours, have you been vomited? So these are the questions which are asked, and then they are scored. How many times she had, and then there is a score. This score generally not asked, but these score and the accordingly the management is important. Okay, so what is the scoring and what is the quantification or the degree, that you should know. Okay, the second score is a hyperemesis level prediction. Okay, this score is again mild, moderate, and severe. Severe is 33 to 60, moderate is 30 to 32, and mild is less than or equal to 19. Okay, so 19 is included into the mild. Okay, this you just remember these particular figures. Okay, less than or equal to 19 is mild, 20 to 32, and severe is more than 33, maximum is 60. Okay, and there are multiple parameters which are used. This score was not there in the previous guideline, but this guideline mentions about the HELP score also. Okay, now coming to the drugs which we have already discussed, the first line, second line, and third line. First line is a doxylamine and pyridoxine, 20 milligram. orally at night. Okay, increase additional to 10 milligram in the morning. Okay, and at lunchtime if required. Then other is cyclizine, prochlorperazine, promethazine, and chlorpromazine. Doses are not asked, so you need not remember all these doses. The second line we have seen metoclopramide and domperidone and ondansetron. Okay, so these are the second line drug, and here also it is clearly mentioned women take ondansetron may require laxatives if constipation develops. So this particular line is also very, very important. Okay, then third line, hydrocortisone 100 milligram BD. Okay, that we will convert once stabilized, we'll convert it to oral 40 to 50 milligram, then taper it down weekly. Okay, and then gradually stop it. Okay, and also screen for the glucose intolerance. Okay, now what investigations you have to do? Urine analysis. Nitrous will indicate the infection. Okay, and Millstream urine we have to do if there is a dipstick is suggestive of signs of UTI. Okay, then urea and electrolytes daily. This electrolyte imbalance we have seen. There can be hypokalemia or in hyperkalemia if okay, but that will be present in patients with chronic kidney disease, and because of acute kidney injury there may be high creatinine urea. So these are the severe cases, but routinely what you get, low sodium, low potassium, low urea, ketone urea. Okay, and increased hematocrit. Okay, so these are the things which can and investigation which you have to do. Okay, so about these investigations, thyroid abnormalities we have seen, LFTs we have seen. Okay, these abnormalities, so these investigations are required. Now this is the flow chart of the management. Okay, here the score of pregnancy unit quantification of MSC score up to 12, 3 to 12, and there are no complications, the patient can be managed in the community. Then if the pregnancy unit quantification score is more than 13, but there are no complications, there is inability to tolerate oral intake, and community measures have failed, you go for ambulatory daycare management. Okay, and these are the questions which are asked as a SBA as a next step. Where will you manage? What is the management level? Okay, so if the community management and failed, and what is the score? So even if the score is more than 13, but there are no complications, you still can manage these patients into ambulatory daycare. Okay, then what are the indications for inpatient admission? Any score with complication. Okay, any score, but there are complications, then inability to tolerate oral intake, unresponsive to outpatient management, clinical dehydration, if there is a weight loss more than 5% body weight, and confirm or suggest suspected comorbidity like diabetes mellitus, etc., or comorbidity and unable to take oral medication, such as which is the case of epilepsy or HIV. In that particular case, you need to admit. And if there are concerns regarding her mental health, you have to admit these patients. Okay, and in community management, we have seen what are the safe drugs. Okay, so that finishes the guideline. Thank you.